So now let's discuss E. coli infections. So Escherichia coli infections. E. coli is the most important species encountered as human pathogen. So it is also the most common aerobe to be harbored in the gut of humans and animals. It is an aerobe. Okay. So after it is excreted in the feces, it remains viable only for some days in the environment. So that is why when you detect E. coli, especially a variant called thermotolerant E. coli which survives at 44 degrees, it is an indicator of recent contamination of drinking water with human or animal feces. So basically remember it like this. So coli, so Virat Kohli, he likes girls, right? So girls like pink, so gram negative. And also girls like sugar and cats, so cats positive, catalase positive, and sugar, so lactose fermenting on McConkey's agar. And Virat Kohli moves, right? He's a sportsman, he's a cricketer, so it is motile. So virulence factors can be grouped into surface antigens and toxins. So surface antigens, there are 4 surface antigens. Virat Kohli says okay fine if he's angry. So O, somatic, flagellar H, capsular K antigens, and fimbrial antigens. Okay, so what are the toxins? So exotoxins are of several types. You have enterotoxins, and also okay fine, I'll have a kunafa. Okay, so CNF, cytotoxic necrotizing factor 1, CNF1, and also SAT, secreted autotransporter toxin. So moving on to various properties of enterotoxins of E. coli. So basically you have heat labile, so labile toxin LT, stable toxin, heat stable toxin ST, and also verocytotoxin or Shiga toxin. So basically LT toxin is produced by enterotoxigenic E. coli. It resembles cholera toxin in its structure and function, but it is less potent than the latter. Mechanism of action, it has 2 fragments, A and B. Okay, B for binding, A is the active fragment. Now, a heat stable toxin, it is produced by enterotoxigenic E. coli. Mechanism of action, so it is heat stable, right? So it can deal with enzymes. So it binds guanylate cyclase C, increases cyclic GMP in the gut, causes fluid accumulation and diarrhea. So next, verocytotoxin or Shiga toxin, Shiga S, right? So 60S ribosomes, the active one inhibits it, and B peptide, it binds to GB3 receptors, so globotriaosylceramide ceramide receptors. Okay, it is produced by enterohemorrhagic E. coli. He likes her, he likes she, so Shiga toxin, hemorrhagic he. Okay, so mechanism of action and all this, and cytotoxic to Vera cell lines. So also LT toxin, it is plasmid coded, ST is plasmid coded, but verocytotoxin or Shiga toxin is bacteriophage coded. So detection, latex agglutination test, ELISA and PCR, same heat stable also all these tests. But again, bacteriophage coded, LAT, ELISA and Vero lines because it is cytotoxic to Vero and HeLa cell lines. Okay, and also specific DNA probe. So clinical manifestations, basically remember 6 types, right? So pitta, so enteropathogenic, enteroinvasive, enterotoxigenic, enterohemorrhagic, adherent and aggregative. Okay, so diffusely adherent and enteroaggregative. So urinary tract infections are caused by uropathogenic E. coli, which are UPEC. So what are the clinical manifestations? So basically abdominal infections, then pneumonia. Okay, lungs can be infected. Next, meningitis, especially neonatal meningitis, wound and soft tissue infections, and blood is affected, so endovascular infection, bacteremia. Bones are affected, blood, bone, so osteomyelitis. Next, prostate, bacterial prostatitis, it is the most common cause. What is that? E. coli infection. Next, you have meningitis, wound and soft tissue infection, pneumonia, and abdominal infections. Next, sample collection, it depends on the site of infection, so urine, stool, pus, wound swab, blood, CSF, etc. So direct smear, you can see gram negative bacilli and pus cells. In culture, you can, on blood agar, you can see grey moist colonies. On McConkey's agar, you can see flat pink lactose fermenting colonies. Okay, we discussed Virat Kohli likes girls, so pink, and also girls like sugar, lactose fermenting. Sample collection, what are the specimens collected? So in diarrhea, you collect stool. UTIs, you collect urine, midstream urine. And then cellulitis or wound infection, you collect the pus or exudates and wound swabs. And then meningitis, CSF, peritonitis, peritoneal exudate, bacteremia, blood, pneumonia, tracheal aspirate, pneumonia, sputum, etc. So basically Virat Kohli is Indian, right? So India, Indole is positive, IQ tests, rest all are negative. Okay, and the culture smear and motility, you can see motile, gram negative, bacilli. Automated systems such as Malditoff or Vitek, and obviously Virat Kohli likes girls, her, so she. Girls like cats, so catalase positive, oxidase negative, and antimicrobial susceptibility testing can also be done. Okay. Next, Moving on to the treatment of E. coli infections other than diarrhea. So treatment is essentially based upon an antimicrobial susceptibility test report. The majority of E. coli acquired in hospitals are multi-drug resistant. So they are resistant to greater than 3 classes of antimicrobials, mostly aminosillins, third generation cephalosporins, quinolones, cotrimoxazole, etc. So how do you treat them? So carbapenems, amikacin or beta-lactam, beta-lactamase inhibitor combinations are the agents of choice for hospital-acquired MDR E. coli infections. Polymyxins, fosfomycin or tigecycline are the next-line antimicrobials for carbapenem-resistant isolates, and the prevalence of carbapenem-resistant E. coli is seen in India. It is about 11 to 27% as of 2019. So, in healthcare facilities with high prevalence of multi-drug resistant E. coli, empirical treatment should be started with higher spectrum antimicrobials such as carbapenem. Therapy can be tailored based on the susceptibility report. Diarrhea. So, diarrhegenic E. coli, they are antigenically distinct and different from the commensal E. coli, which colonizes the intestine. Only a few serotypes of E. coli which express the enterotoxin or other virulence mechanisms can cause diarrhea. And WHO estimated that greater than 300, all these numbers. And there are 6 pathotypes of diarrhegenic E. coli, so PIT, HA, PITA. So first, P, enteropathogenic E. coli. So enteropathogenic, P for pillalu, remember kids, okay? So it causes infantile diarrhea, and pathogenic, right? So person to person spread is seen. It is non-toxigenic, non-invasive. I and T is not there, right? So that is what it indicates. So how does it occur? So basically the mechanism of diarrhea includes adhesion to intestinal mucosa mediated by plasmid coated bundle forming pili. Okay, bundle forming pili which form cup-like projections called pedestals. So these pedestals, they attach to the mucosa, they cause A&E lesions. So attaching and effacing lesions, they are typical lesions produced when the intestinal epithelium lead to disruption of the brush border epithelium, causing increased secretion and watery diarrhea. So next, moving on to ETEC, toxigenic E. coli. So T for travelers. It is the most common cause of travelers diarrhea, causing 25 to 75% of cases. Causes acute watery diarrhea in infants and adults. It is toxigenic but not invasive. Okay, so what is the pathogenesis? Travelers C far, right? So CFA. So attachment to intestinal mucosa is mediated by a fimbrial protein called CFA, colonization factor antigen. Okay, so toxin production, you have labile toxin and stable toxin. Labile toxin acts by increasing cyclic AMP, labile and stable. Okay, STA. LA is directly having A in the spelling after L, so cyclic AMP. ST is cyclic GMP. And diagnosis is by detection of toxins, which is the mainstay of diagnosis. Moving on to entero-invasive, it is invasive but not toxigenic. So because T is not there in the name. So it is biochemically, genetically and pathogenically closely related to Shigella. Okay. So the epithelial cell invasion is mediated by a plasmid coated antigen called virulence marker antigen or VMA. So invasive, it is virulent, right? So virulence marker antigen VMA. Next, manifestations, you can see bacillary dysentery resembling shigellosis. Okay, diarrhea with mucus and blood. So diagnosis, again detection of VMA by ELISA, HeLa cell line invasion assay, and biochemically atypical. Okay, it resembles Shigella. Okay, so it is atypical as per E. coli, so it is non-motile and lactose non-fermenting. Enterohemorrhagic E. coli, so it is prevalent mainly in industrialized countries. So H for hectic in industrialized countries. Serotypes associated, so O157H7 is the most common serotype. However, other strains may account for EHEC infections, out of which O104H4 strain of EAC is important. So enterohemorrhagic E. coli, it is transmitted by contaminated food, okay, and undercooked ground beef. Recent outbreak of EHEC in 2020 was reported in the US due to consumption of clover sprouts contaminated with E. coli. So low infective dose is required to initiate the infection. So pathogenesis, so he likes she, okay, so Vera, it is cytotoxic on Vera cell lines. So basically she for S also for 60, right? So ribosomal subunit, 60S ribosome is inhibited, so it inhibits protein synthesis. And this Shiga, right? So it actually secretes a toxin called Vera cytotoxin or Shiga toxin, and it resembles the Shiga toxin produced by Shigella. So it inhibits the protein synthesis and inhibits 60S ribosome. It is of two types, STX1 and STX2. So manifestations, Shiga toxin has a predilection for endothelial cells causing capillary microangiopathy, which leads to hemorrhagic colitic uremic syndrome. So hemorrhagic colitis, hemorrhagic uremic syndrome. Next, EHEC diagnosis. So hemorrhagic, right? So MO for monkey, so McConkey agar, it does not ferment sorbitol, and also red, right? So rainbow agar is used. Toxin detection, you can use cytotoxicity demonstration in Vera cell lines, which is a gold standard method, and fecal toxin detection by ELISA or rapid tests. Moving on to enteroaggregative E. coli. So aggregation in a stacked brick-like fashion, it adheres to Hep2 cells, okay, in a distinct pattern in a stacked brick fashion. Most strains are O1 typeable, H typeable, okay. So enteroaggregative, right? Pathogenesis, intestinal colonization is mediated by aggregative adhesion fimbriae, regulated by the AGGR gene, AGR gene. So it also produces East1 toxin, enteroaggregative, heat stable, and enterotoxin 1. So manifestations, E. coli, EHEC, okay. So it causes persistent and acute diarrhea. So aggregative, right? So it is persistent. Persistent diarrhea is commonly seen in developing countries. Also cause traveler's diarrhea and persistent diarrhea in infants. So diagnosis, Hep2 adherence, which is the gold standard test, and also detection of AGGR genes by PCR. And E. coli 0104 and H4, it is an enteroaggregative strain, accounts for EHEC infections. Okay, it produces Shiga toxin and can cause HUS. Next, diffusely adherent E. coli, DAC. So it also has an ability to adhere to Hep2 cells in a diffuse pattern, not a stacked brick pattern, diffuse pattern. So it expresses diffuse adhesion fimbriae, not aggregative adhesion fimbriae, which contribute to the pathogenesis. It is capable of causing diarrheal disease primarily in children aged 2 to 6 years. So treatment of diarrheogenic E. coli, mainstay is fluid replacement. Avoid antimicrobials as much as possible. But when should you use antimicrobials? In traveler's diarrhea, thigh, okay, thigh travelers, so, and EHEC, EAC, and EIC, okay. So treatment of diarrheogenic E. coli, so traveler's diarrhea, use azithromycin. Next, EIEC, azithromycin, EHEC, azithromycin, okay. In EIEC, only in immunocompromised patients, use ciprofloxacin for 3 to 7 days.